Dr. Abu-Raddad's expertise lies in several areas of infectious disease epidemiology, with emphasis on quantitative methods, including mathematical modeling and biostatistics. He has led several high-impact studies at the international and regional levels. His scientific research has been published in leading journals such as Science, Proceedings of the National Academy of Sciences, Lancet, Lancet Infectious Diseases, Translational Medicine, and AIDS. He has worked on HIV, herpes, simplex virus 2, hepatitis C, tuberculosis, and SARS. He is or has been key personnel on several grants funded by various funding agencies and acted as an expert advisor or consultant for several international organizations. Findings of his research studies have received global coverage in national, regional, and international mass and print media through numerous articles and interviews in such websites as Al Jazeera, BBC, New York Times, and The Economist. So if you can all give a hand to Dr. Laith J and welcome him. Thank you.
Yeah, thank you very much, Sami, for the introduction and for the invitation here. So today I will be speaking about the emerging phase of the HIV epidemic in the Middle East and North Africa. To start with, actually, there are different definitions of this region. So here I will be using a more broader definition of the region, which actually start with Morocco here in the west and going actually as far east as Afghanistan and Pakistan. So it's more broader than what's conventional, and the reason has to do actually with HIV programming. So a lot of the work on HIV programming actually focused on this region as a whole, including World Health Organization, World Bank, UNAIDS, and so on. So this definition actually includes the definition of countries in all of these UN agencies, and this is why we actually use such a very broad definition of the MENA region. Okay, so I will be focusing more on the big picture of the HIV epidemic in the Middle East. This is the result of actually a 10-year study now on HIV, which is actually the largest study to date on HIV infection in this region. Okay, so to begin with, what is actually a very key aspect of this of the infection? To begin with, the HIV population prevalence continues to be actually very low, and in fact appears to be below 0.2% in most countries. What do I mean by 0.2%? 2 in every 1,000 people are actually infected with HIV, which is actually very, very small compared to many regions around the world. So here is actually results of HIV testing from this region in different population groups. This is actually a result from a database of over 53 million HIV tests. It shows you how really it's very, very low. So among blood donors, it's actually below, in less than 1 in 1,000, pregnant women, premarital testing, and so on. So this is the bright side, actually, of HIV infection. Overall, the rates continue to be actually quite low, but these rates actually hide something which is more grim, which are the emerging HIV epidemics among high-risk populations, including people who inject drugs, men who have sex with men, and female sex workers and their clients. So here is a picture of this in Pakistan. So HIV prevalence among injecting drug users have been actually growing very rapidly. It grew from about 11% in 2005 to 16% in 2006, to 21% 2008, and then 27% in 2011. So it's a very, very rapid actually growth of this HIV epidemic among injecting drug users. And now actually Pakistan has one of the largest HIV epidemics actually in the world among injecting drug users. At the same time, there was actually an emerging epidemic among men who have sex with men. So the prevalence have grown from 1% in 2005, which you see here, then to 2% 2006, 6.4% 2008, and 7% in 2011. So this is actually one example of these emerging HIV epidemics in the region among high-risk populations, specifically injecting drug users, men who have sex with men, and female sex workers. And this story that's happening in Pakistan is actually happening in other countries as well. So now I will actually speak in more at depth about these actually groups. I will start with people who inject drugs. So this is a picture of a person who injecting drugs at the border between Pakistan and Afghanistan. Injecting drug use is actually a very serious problem in the region, and in actually good part of this because the region is actually the major producer of heroin in the world. Actually, over 90% of the world's heroin is produced within the region here in Afghanistan, and much of this actually get smuggled everywhere through also the region. So, for example, Iran alone actually has nearly 40% of the world's heroin actually passed from Afghanistan to Iran and so on to the rest of the countries. So it's a very serious actually a problem. And drugs are really widely available. They are actually inexpensive. Believe it or not, sometimes a shot of heroin can be as cheap as actually a can of Coca-Cola in some countries, just because of the huge availability of the drugs. So what do we know about people who inject drugs? So there are nearly 1 million injecting drug users in this region, this wider region. So overall, the population fraction is 0.2%, which means 2 in every 1,000 people are actually injecting drugs. This is in the intermediate range compared to other regions. So it's not necessarily the worst compared, let's say, to East Europe and Russia, but also not one of actually the lowest. It's more actually around intermediate range. But this really hides how actually various it is within the region itself. So the injecting drug users issues are actually very high in this corner of MENA here, which is actually happens to be the corner where the drug is being traded and smuggled to everywhere, and much less so, let's say, in the western side, in the Maghreb, like Morocco, where it's actually much lower. So, for example, the rate of injecting drug use in Iran, or the fraction of the population who inject drugs in Iran, is actually 10 times as much as it is in Morocco, as a consequence of this. So we have actually areas with very severe problems of injecting drug use, and we have heard this morning much actually about Iran, and areas where the problem is actually much less severe than is the case. So what do we know about the HIV epidemics among injecting drug users? We know actually we have now conclusive evidence that at least 1/3 of MENA countries are affected by emerging HIV epidemics among people who inject drugs. For the rest of the countries, for a few countries actually we have evidence, but it doesn't appear there are actually HIV epidemics. And for others, we actually don't yet have enough data to make a conclusive statement. Very interestingly, these actually epidemics emerged very much early 2000 and after. So actually a lot of the epidemics just emerged over the last few years. Here are 2 examples of Iran, where it was just after 2000 that the epidemic exploded. And now we have a national prevalence of 15%. 15% of injecting drug users are infected. Pakistan, similarly here. It's also just very quickly after Iran, the epidemic started in Pakistan. And it's already about 1 in 3 actually injecting drug users are infected with the virus. So these 2 actually are really very large epidemics among this population group. For the rest of the countries, for most of them, they have actually smaller epidemics, apart from Libya, which actually has a huge HIV epidemic among injecting drug users. But still, this is actually a very major concern for the region. So here is actually an example of smaller epidemic in Egypt. This is where HIV prevalence was only 1% in 2006. 4 years later, it has already grown to actually 7%. So this kind of gives you the big picture for people who inject drugs. Now we move to men who have sex with men and HIV. This is actually a picture of a transgender population from Pakistan, the Hijra, very actually famous and historical group, which is currently, unfortunately, is affected by an HIV epidemic. Actually, the HIV epidemic that I started with, which is growing in Pakistan, it's actually growing specifically among this population. Now, men who have sex with men is a group which is quite very difficult to work with, as you mentioned, in the region, but it's actually remarkable how much actually have been done over the last 10 years. So 10 years ago, when I actually started working on this, many public health officials would not even acknowledge the existence of MSM in their populations. And now actually not only that, we have actual studies, and even in some countries we even have programs, including governmental actually sponsored programs working with men who have sex with men. So what do we know about this population? We know that about 2 to 3% of males actually have sex with other males in the region. So this is comparable to international levels, but from the low side. So it still seems to be actually lower than global numbers. We see, however, higher, of course, ratios among specific populations like truck drivers, injecting drug users, prisoners, where we see higher, actually, sex between males. But overall, again, it's more comparable to international levels, but more actually from the lower side. Now, what about HIV actually infection in this population? Actually, now we have conclusive evidence that at least half of MENA countries are actually affected by these emerging HIV epidemics among men who have sex with men. Here, this figure shows you actually HIV prevalence from many studies, actually hundreds of studies, or point prevalence measures have been done among men who have sex with men. And it's very remarkable. Actually, the epidemics very much everywhere started actually after 2003. And they started one country at a time and then moved from one country to the next and so on. Still, however, several groups actually of men who have no epidemics. I mean, there are countries where actually still appears to be zero HIV prevalence among this population. Here is just a very specific example, Tunisia, where the HIV prevalence was 5% in 2009. Among MSM, and already increased actually just 2 years later to 13%. So I really like to actually highlight really how remarkable the region actually has done in relation to men who have sex with men. Just within actually a decade, a group which was virtually not even acknowledged. Now we have actually studies, we have programs and so on, which really speaks to how much things could be actually get done in the region, despite many perceived actually concepts about the region and the difficulty of dealing with such sensitive issues. Now we move to female sex workers and HIV. This is actually a picture of a female sex worker in one of the actually affluent cities of the Middle East. Sex work have changed a lot actually in the last two decades. This is not only true of course, in the region, it's true actually globally, part because of globalization, part because of the changes in socioeconomic conditions, and actually a great deal of that just simply because of technology. I mean, now cell phones actually revolutionized actually the practice of sex work actually globally. Now it's said actually cell phone is the new pimp of the modern age, basically. So it's become actually so much easier to actually have these networks and build them. So sex work used to be very discreet in the region and highly actually localized. And this really has changed for a good part of the region. I mean, there are capitals in the region where sex work is just quite actually visible and is very, you can see it very easily, including places which used to be very conservative actually in the past. So what do you know about this population? There is one female sex worker for every 100 to 1,000 women in MENA. So out of each 100 women to 1,000 women, it depends on actually the country, there is actually one sex worker over there. So this, in terms of comparison to globally, it's actually more on the low range. So this is in terms of actually numbers and ratios of sex work. In terms of HIV prevalence, actually in many countries, we continue to see very little HIV prevalence. In fact, quite often zero among female sex workers. It hasn't really spread much in really good part of the region. And even though we have actually a lot of really prevalence measures and studies among them. We see in some other countries low prevalence, usually like 1 to 3% in just a group of them. And in just very few countries, in Djibouti, part of Somalia, part of Sudan, especially the western side, and South Sudan, we see actually much larger HIV epidemics among commercial sex. But again, these are really more the exceptions rather than the rule. So overall, still HIV is actually quite limited in this population. Despite this, actually, even though HIV prevalence is low, it's still commercial sex is a major driver of a large fraction of HIV infections in this region. This has to do actually with the scale of this population. Female sex workers and their clients is actually much larger fraction of the population than men who have sex with men and injecting drug users. So even though the prevalence is low, it actually results in a lot of infections. And we have seen this actually, for example, recently in a study we conducted in Morocco to map the modes of exposures to HIV. So commercial sex networks contribute actually right now about half of HIV infections in this country, even though HIV prevalence is only 2% among female sex workers. So very low prevalence, but actually nearly half of HIV infections are coming from commercial sex networks. Here actually is good maybe to point out that Morocco is a very special country in the region. It's actually very progressive about HIV, even not only relative to the region, but actually by global standards. And it's a country where we know so much about the epidemic now. We actually literally map HIV infection to a really very, very good degree actually throughout the country. So this is about female sex workers. Now, one aspect of HIV epidemiology that we see is the overlap between the different groups. So these actually three populations overlap substantially. For example, injecting drug users is actually a large fraction of them exchange sex for drugs or money in order just to get actually drugs. So then they become, through this, actually connected to men who have sex with men. They also injecting drug users usually frequent actually female sex workers, and this is actually very evident in the studies. So this also connects them to female sex workers. Similarly, actually in some countries but not others, good fraction of female sex workers are actually injecting drug users also. So this also overlaps them with injecting drug users, and some of their clients are, of course, also could be injecting drug users. So through this, really, it's very easy for HIV infection to start in one population group and move to another one through this overlap of risk behavior. And this is what we have been actually seeing. A classic example to this is actually Pakistan. So the epidemic among injecting drug users started just shortly after like 2002 or so. And just 2-3 years later, the same epidemic actually started among hijras, the men who have sex with men, the transgender population. And they were growing actually in unison. As you can see, as the IDU epidemic grows, the epidemic among men who have sex with men actually grew. And we know it's actually the same virus because there have been actually molecular epidemiology work on the virus subtype, and it's actually the same virus that started among injected drug users moved actually to men who have sex with men through this overlap of risk behaviors. So this is one example from Pakistan. In Egypt, it appears something like this has happened, but we are not yet actually conclusive. Egypt, the first epidemic that started was actually among men who have sex with men, where already 6% in 2006 were actually infected, and it seems to be stable, at least up to 2010. But then the HIV epidemic among injecting drug users actually started growing after that. So it could be the infection have moved from men who have sex with men to injecting drug users. But again, we don't yet have actually molecular epidemiology work to really link the two epidemics exactly. So these are just general features. Now just kind of a summary of what we know. So really, HIV epidemics in the region are actually a reality, but only a reality among these key populations, the high-risk populations. Outside these risk populations, very, very low really HIV infections are found. Very much the vast majority of HIV infections are actually happening in these populations or in populations connected to them. For example, usually women normally get affected by the epidemic actually through their spouses. I mean, the key risk factor for women to get infection in the region is actually marriage. So this is because they get it normally through their wives. But how much of actually women engage in risk behavior is actually much, much low. I mean, very, very large. We're talking about over 90% of women normally get their infection from their husbands actually in the region. So very much HIV infection transmission is focused among these high-risk populations. And we have now really lots of evidence. These epidemics are actually quite recent. I mean, the region, it took it actually over 2 decades after HIV epidemics emerged in other parts till it actually emerged here. So it took much longer time for it to emerge. However, some of these epidemics have been growing very fast. I've just shown you the Pakistan example. Others have been growing slowly, but overall, the trend is actually growing, which is opposite to the global trend. So it took time for the epidemics to start, but now they are growing. Meanwhile, the epidemics globally are actually in decline. So it's not in sync with the global HIV epidemic. In several countries, the epidemic is still actually driven by only one key population. Let's say Iran. So it's really still heavily actually an injecting drug use epidemic. The same story in Pakistan, Afghanistan. We haven't yet seen like large HIV epidemic among men who have sex with men or sex workers. It's another key feature is that in many instances we see really geographically clustered infection transmission. Sometimes actually epidemics could be even isolated in one city. That's it for the whole country. So here's an example for this actually, again, coming back to Morocco. So they have a substantial epidemic among men who have sex with men, among also female sex workers and clients, even though the prevalence is low. But a lot of that is actually focused in the south of the country, here around Agadir, Susma, Sadra, and actually Marrakesh, where very large number of HIV infections are actually happening through sexual transmission, the vast majority, much less so for the rest of the country. For injecting drug users, however, it's actually the only epidemic we have is actually in this area here, which is in Nadur, where we have actually HIV prevalence over 25% among injecting drug users. It does not appear so far that the infection has moved to other injecting drug users within the country. There is now very recently some evidence suggests maybe Tatwan could have been also affected, but this is not yet conclusive because, but we have a study over there ongoing currently. So we could have highly heterogeneous infection transmission within actually the country. So not all the whole country affected by the epidemics. Despite actually this geographical heterogeneity, what we see also some kind of regionalization. So some of these high-risk groups, let's say men who have sex with men, they may not be connected within the same country, but the same group could be connected actually to a different country. Just speaking of Morocco, the epidemic actually in Nadur is actually part of the HIV epidemic in Spain. In fact, actually, Nadur is just an area which is bordering with Ceuta, which is a Spanish enclave in North Morocco. And actually, there is an HIV epidemic over there in Spain. And through this, actually, there's a lot of smuggling between Nadur and Ceuta, actually. And through this, actually, the infection came. So it's really very much part of the Spanish epidemic rather than actually the Moroccan epidemic. But we see this regionalization also further in the region. In fact, we have even like kind of 3 patterns so far. We see regionalization of epidemics among injecting drug users here in Iran, Afghanistan, and Pakistan. It appears all of these epidemics are actually linked together. So we know, in fact, for sure that the first epidemic was in Iran, and we know for sure the same virus moved to Afghanistan after the fall of the Taliban. So Afghan refugees were going back to Iran, and they brought with them actually the infection to injecting drug users in Afghanistan. This is, we know, we have actually molecular epidemiology work linking this. It's possible also the same actually virus that grew in Iran could have actually went to Pakistan. So the Pakistan epidemic could have been started also by the virus that was spreading in Iran, but we are actually not yet certain about this, but appears to be so. So this is in terms of regionalization of epidemics among injecting drug users. The other actually one is these epidemics among commercial sex networks, female sex workers and then clients, and actually they are in this part. So we know that Djibouti had actually very large epidemic among female sex workers, but that was very strongly linked to the epidemic in Ethiopia, which is right next door. Somalia, northern Somalia is actually has very linked epidemic to the one in Djibouti. And could be also this relate to the epidemic in west side of Sudan, but also this not actually conclusive yet. But it seems there is some kind of regionalization, the same epidemics among commercial sex networks. Now, the third one, which is quite intriguing, and actually this is really very recent, just in the last couple of years we start seeing this. It seems the epidemic among men who have sex with men in Egypt, Jordan, Lebanon, Syria are actually linked. So the epidemic started in Egypt. It appeared to have moved to Lebanon, and then actually to Jordan and Syria. It's not yet conclusive, but actually all of these countries are affected by epidemic among men who have sex with men. And in the case of Lebanon and Jordan, this is the only group actually that's affected. We don't see HIV outside men who have sex with men. So here is kind of a summary. Sorry, the table may not look very, very clear. It's actually just summary of what we know about the status of the epidemic in each country of this region. But really the point here is that for some countries, we know actually very well. Let's say Morocco, we know very well the status, and we know there are actually epidemics among all of these key populations. In other countries like Afghanistan, we know there is an epidemic among injecting drug users. We know there is no epidemic among men who have sex with men, and there is no epidemic so far among female sex workers. So we have the data. However, in other countries, let's say Saudi Arabia, we actually know very much nothing, actually, about the status of the epidemic. This is true in, let's say, United Arab Emirates, unknown. Simply, we don't actually have the data to know. So our knowledge of the epidemic is highly actually variable across these countries. And this brings the question, could there be actually hidden HIV epidemics among the key populations and countries where we don't actually have data? This could be actually the case. It could be also not the case, but there are actually warning signs about this. A very good example of this is actually Libya. So in Libya, from actually the 90s, we had some HIV testing starting among injecting drug users, and it was consistently showing no HIV infection. But then around 2000, they start seeing a lot of cases of HIV infection, actually among injecting drug users. But no study was done on this population. And this data continued. I mean, by 2010, actually in a rehab center in Libya, 84% of those injecting drug users were actually infected with the infection. So we had the signs since 2000 that there could be a problem over there, but no study unfortunately was done till 2010. And then when the study was done, they discovered that actually HIV prevalence among injecting drug users is 87%. So in other words, virtually all of these injecting drug users were actually already infected with the virus. This is, by the way, actually the largest known HIV prevalence among injecting drug users globally in a representative study, actually. I mean, a probability-based sample. So there were actually signs, but unfortunately, nothing actually was done about it. And interestingly, it appears the epidemic was started because of a very unfortunate policy decision by Gaddafi, who basically led to this actually very mass HIV epidemic. So it could be the same stories happening in these countries where we actually don't yet have enough data. And we do actually have some signs about this. So here is an example of recent case notifications. These are the most recent ones from 2012 that we have. So if you look at Saudi Arabia, you see 30% of new HIV infections in 2012 were actually among injecting drug users. It's very difficult to get that large fraction of infections among this population without being actually a substantial epidemic over there. But unfortunately, we don't have a study to confirm this. Same story, let's say, about Oman, where close to 30% of infections are among men who have sex with men, the new diagnoses. We don't have a study, unfortunately, but again, it's very difficult to reach this percentage without actually having very large epidemics among men who have sex with men. In the US, for example, 40 to 50% of HIV infections are among men who have sex with men, new diagnoses, because there was and continues to be a large HIV epidemic among men who have sex with men. So we do have the signs, but unfortunately, we don't yet have the studies to see what's actually the true status of the epidemic. Speaking of which, it's not actually always, even when we conduct studies, to know also the status of the epidemic, because it's really very, very, very complex process. Actually, two good examples of this are Jordan and Lebanon. So in these two countries, we had actually very good studies done over the last few years, and all studies reached very much the same conclusion. HIV prevalence is 0 among men who have sex with men. In fact, at about the same time the studies were done, we start seeing a lot of anecdotal evidence that suggests there is substantial HIV transmission among men who have sex with men. The diagnoses were happening among men who have sex with men. NGOs were reporting actually infections who are working with MSM reported these rising actually infections among them and so on. So the evidence suggests there could be actually infection. In fact, in Lebanon, the new diagnoses in 2012, half of them were among men who have sex with men, very similar to the US. So how come we did not see the epidemic when the study was conducted? Probably because the networks of these high-risk populations are actually quite complicated. They may not be as much connected to each other. The study may have actually just captured only one part of the MSM population, but not the whole MSM population, because it could be very, very different actually networks, especially for the methodology for studying this population actually depends on it's called actually respondent-driven sampling. So it depends a lot on actually the MSM themselves propagating through their networks. But now there is actually a new study in Lebanon, so hopefully and actually in Jordan as well. So we'll see whether actually the situation change. So let me now just summarize what I have been actually describing. So we do have established but largely emerging HIV epidemics among these high-risk populations. HIV trends are actually increasing rapidly right now. That does not mean necessarily a huge number of infections, it just means year by year the numbers are increasing in relative terms a lot. There appears to be substantial potential for more actually epidemics just based on the levels of risk behavior we see in these populations. So we suggest we really need to do more in prevention, specifically to expand HIV surveillance and actually expand access to HIV testing, prevention, and treatment services. And we've seen in the morning really this issue of HIV testing is very important, access to HIV testing. So hopefully this will be improved. It has improved a lot in some countries, but not necessarily in all. So last but not least, just to acknowledge actually the funders of this research and actually the team which has been working on this project. Thank you very much for listening.
Thank you so much, Laith. That was really informative. I think we all got a lot of information out of that. Do we have any questions? Yes.
Thanks. Hi. So you spoke a lot about people who inject drugs specifically. I know from other regions in the world that there's recently been evidence emerging that people who use drugs, there's a correlation between that population and HIV as well, and although it's not nearly as high, that it is significant, especially from an epidemiological standpoint. And I was wondering if you could speak to that specifically in the Middle East, if that research has been done, if there are programs being implemented. Thank you.
Yeah, certainly. Yeah, the research has been done, and actually we have in some countries massive HIV epidemics, such as Libya, among actually injecting drug users. So the problem is actually there, but not in every country. Some countries we actually see very, very little HIV among injecting drug users, let's say Jordan, Lebanon, and so on. Now, in terms of what being done about it, it really varies a lot from one country to country. Iran actually it has done actually very, very well, in fact. I mean, I've seen examples this morning, actually. I mean, it's actually more progressive, by the way, than even the federal government in the US. I mean, like needle exchange programs, still federal government won't even support it in the US. So they have done very good in terms of harm reduction in Iran. But that's more actually, unfortunately, the exception. Morocco have done actually well as well, but they just started. For other countries, still very, very limited actually work done. Yeah, so this is the situation, yeah.
Just to clarify though, is there work being done with people who use drugs, so people who are not injecting drugs but are still using drugs?
Really, this way, it's not actually my area. Really, the focus is among injecting drug users because of HIV. The other ones are not at risk of HIV. So I'm not actually as familiar, yeah, thank you. Yeah. Sorry, yeah. Yeah.
I have two questions. questions. One was, thanks. One was about sex tourism. So how does that affect the spread of HIV? I'm thinking about sort of, Western sex tourism to North Africa, but also, about people, let's say, from the Gulf who visit more liberal Arab capitals, and then if they are infected, they sort of go home, so to speak, with the virus. And the second question has to do with sort of the politics of data collection and prevention. So one of the things that I found fascinating in your talk is that you were saying that certain countries don't provide the data, I presume because of politics. And then other countries have, kind of problematic methodologies. So how do you meet the challenge of providing prevention and so on when attaining the data itself is so problematic?
Yeah, actually quite complex question. So relation to actually commercial sex. It's everywhere actually right now. Now you might be actually very surprised. So you mentioned some people from, let's say, the more conservative parts going actually to the more liberal for sex tourism, which was the pattern originally. But now it's actually the other way around. I mean, for example, one of the hubs actually of HIV transmission, I mean, you'll be very, very surprised. I mean, quite a number, let's say, of Lebanese who got HIV infection actually got it in Dubai. Yeah, it's exactly the opposite of what you would expect, even though historically it was the other way around. Because Dubai, there is a very booming actually commercial sex linked, actually a lot of them are Eastern Europeans, actually from everywhere, but somehow they have East Europe actually contribute substantially. So and Dubai became actually a tourist hub for the whole region. So people normally go there, do shopping, have sex, and actually come back with HIV infection. I mean, I've seen actually this multiple times. And ironically, actually, speaking of Dubai, so the Gulf has very strict policies about HIV. Every person has to be tested for HIV infection in order to actually have residence in the countries. The only group that's actually excluded from this are actually sex workers. They are the only ones who actually do not get tested for HIV, which is very strange, And the reason for this, because they don't come on resident visas. A lot of these sex workers come actually for short-term visas. Usually they come for 2 months, seasons. They actually do work these 2 months, then they leave for several months, then they come back again and so on. So they never actually even get tested. So now in terms of actually doing work, really countries are very, very variable in terms of their work. Let's say in Tunisia, actually sex work is legal. I mean, cities are, have actually government sanctioned brothels, which are actually very fascinating. I mean, like the first time I went there, it was really fascinating. I mean, a brothel, it's legal, it's actually very well organized, monitored, they have access to healthcare, etc. So it varies actually a lot. But overall, I think all of these practices are illegal, but actually countries are increasingly more open to do work with them. But usually they always want to do things discreetly. I mean, you can do whatever you want in terms of program, but provided it doesn't reach actually the public, it's actually okay. Yeah, so this is generally actually the attitude. So and this continues. So it's unfortunate now. Sometimes some groups actually have interest, let's say, in taking things, into the public sphere, which actually have harmed even HIV offers, because governments, as long as things done discreetly, they don't seem to actually bother. Yeah, they even protect it actually sometimes. Yeah.
So, okay, let's work through this together, because I always get very confused by this, and it's all about the politics of collection of data. When I've done research on kind of looking at the epidemics and whatnot, the story always seems to change, but it always seems to be, wait, we know that there's some prevalence, it's just not very high, and then there's an assigning of kind of like risk groups, but then there's a new study that comes out, and I mean, you identified it, which is, wait, it's actually a lot higher than we thought. And my background's in anthropology, and so talking to people, and the more you talk to people, or at least in my situation, they just don't disclose their status. They don't want to get tested, and so as you indicated, it has a lot to do with these like kind of shifting numbers and epidemics. And I guess the rhetoric always seems to be behind it. Well, we got to do something now. We got to do something now, and there's this immediate need to kind of like identify and then fund work in these areas. And I guess I wonder what's the politics behind that. So for example, like the UAE is not, I don't know, maybe you can prove me wrong, but the UAE is not going to fund a study that does work on female sex work or even sex trafficking. And so I guess I wonder, like, how do we identify that as a area, and then how do you then produce in a study, and then how does a UAE, in the little boxes that we always see with the graphs, how does it move up in terms of whether it's MSM or injecting drug users or female sex workers?
Yeah, really, actually, quite complex issue. So, I mean, it's really difficult to capture all of that. Really, it comes again back to each government and their interests. United Arab Emirates is actually peculiar because they are very open in many ways. But for HIV, actually, they are not. And they are really not open about anything related also to sex work or discussion of it, even though it's very visible. I mean, you just go to Dubai, in any of these 5-star hotels, you'll see a lot of sex workers, very visible. So it's just they have no interest. Actually, how we know even anything about the people getting infected in Dubai is actually because of people who went there for tourism and who came back with the infection, and actually because of deportees. Because in the Gulf, they keep testing also their migrant populations. So let's say if you go to many countries, and actually it's a common feature, these are deportees from United Arab Emirates because they are HIV infected. So this is how we actually find out. But they don't themselves, actually, United Arab Emirates do much actually about this. Now, speaking of the other countries, what actually made things change, possible, ironically, is actually money. So, and this is why we know so much more, let's say, about Afghanistan as opposed to actually Saudi Arabia. The Global Fund had a lot of money at some point, and then they actually entice countries. If you do studies among this population groups, we will fund them. And this is why a lot of countries got interested, actually, to get actually this money. For rich countries, they won't even qualify for the Global Fund money, and they had no interest to begin with, so they did not do anything.
Sorry, I just want to ask a follow-up. So I guess my question then becomes, and I know this could go for anywhere in the world, but if there was perfect data on this, how much would the map change? How much do you think it would shift, if it would shift at all? Whether we would find higher prevalence in the general population, and we'd be surprised that would outnumber, let's say, female sex workers. I'm just curious.
Yeah, I think what we'll find is actually mixed picture. So for actually many years, when I started working on this, everyone believed there is a massive HIV epidemic hidden, behind the public eye, and it's being covered up, and etc. I can tell you this is actually not true. Really, the data we have actually from the governments, mostly it's actually we have. The governments actually have been very willing to give us data, sometimes on confidential basis, sometimes, they put conditions, what could be published or not, etc. But really, I don't think there is actually issue of being covered up like large, Yeah, it's just simply sometimes they don't have the data. When studies started, you will be very surprised. Actually, a good fraction of studies found there are no HIV epidemics. It was actually disappointing to many people. The same people who were thinking there is massive HIV epidemic found actually there is nothing. But more recent studies start seeing the epidemic, only because the epidemic is very recent, actually. So as we go on, I think what we are going to see is actually a mixed picture. There are countries simply, probably the epidemics will not grow by large actually margin. I think just they are kind of special, or may grow in some population groups, but not others. And we will find actual places where we could see massive HIV epidemics as well, Pakistan, Libya, etc. So it's really a mixed picture. Yeah.
I actually wanted to ask you a question, Laith, about people who are coming into the Middle East from outside of it and living in the Middle East, whether it's asylum seekers in Israel or the Syrian refugee population or migrant workers from the Philippines. There's a lot of populations that seem to kind of not be or where no one is specifically responsible for in terms of governments or agencies. Sometimes it is with the Syrian refugee population. You have UNHCR and stuff, but I'm just curious if there's any research done on those populations specifically, since there's so much movement involved with them.
Yeah, some actually. Some was done in terms of HIV. Let's say, for example, Somali refugees in Kenya, actually. It happened actually just because there was actually, for they have done about them. But this is more the exception rather than actually the rule. But the link between refugees and HIV does not appear actually to be very, very strong. I know actually a lot of people think because of the massive movement right now, mobility, etc., this could actually contribute. The evidence actually even globally is actually very conflicting. In fact, sometimes even being refugee is actually protective. For example, South Sudan, it was in a civil war. And actually the civil war appears to have actually slowed the HIV epidemic. That's why the prevalence level in South Sudan is actually substantially lower than Uganda and Kenya, because it isolated actually the country. Now, however, HIV seems to be actually increasing because all of a sudden you have this massive investment, coming into South Sudan, a newborn country, lots of actually trade, truck drivers, moving back and forth, sex workers coming from actually neighboring countries. So it creates more opportunities. So I don't think it's really very obvious, the relationship, but does not seem to be a major issue.
Any more questions? Okay.
I worked in Saudi Arabia for the Saudi airline back in the mid-'80s. And in 1986, the Saudis began requiring HIV tests for anyone coming in.
Correct, yeah.
And there were actually, for a short time on the bulletin boards at work, posters in Arabic, which I was told, were warning about both heterosexual and other posters on MSM issues. And there was even talk at the airline of stopping all the flights to Bangkok. There were 3 times as many flights to Bangkok every week as there were to the United States. But I have a question on slide 24. What was the source of that information?
Let me see which slide. This is actually a collection in all the data we have. So when we take all the data we have in all sources, what do we know about actually each country? So let's say, for example, Afghanistan here, yes. It says, yes, there is an epidemic among injecting drug users. This is actually based on several studies, not one study. Okay. So in Afghanistan, we have actually 2 rounds of second-generation surveillance among injecting drug users, which are actually state-of-the-art methodology. We had actually a few other also surveys among injecting drug users on convenience samples. So based on this, we know that there is actually an epidemic over there. Yeah. So each actually statement means multiple studies.
The reason I'm asking is that for Saudi Arabia, on this slide, it's pretty much unknown.
Unknown, yeah, unfortunately.
And yet on another slide, it said very specifically, the overwhelming majority is heterosexual sex. So they're kind of not showing.
This one is really about the status of the epidemic, whether we have an epidemic and what kind of epidemic do we actually have. So in Saudi Arabia, we really don't know what kind of epidemic. But of course, clearly there are HIV diagnoses. People are getting actually infected. But what type of epidemics we actually don't know. Just the fact also there are people infected does not mean necessarily that there is actually a local epidemic. In a country, let's say in Jordan, the vast majority actually of infections up to till a few years ago were all exogenous exposures. So people who, let's say, traveled abroad, came back with the infection, sometimes actually passed the infection to the wife. But this does not mean there is actually an epidemic, necessarily. Yeah, so in Saudi Arabia, what we really know are just HIV diagnoses. This one, actually, they provide the data. And 30% of them are among injecting drug users. So this is why we say possibly there could be an epidemic, but we are not sure. Yeah.
We have one more question over here, and then we'll move on to the next panel.
Hi, thank you for your presentation again. It was very informative. I noticed that a lot of the studies, and I'm sure this varies on a case-to-case basis, but I noticed that it focuses mostly on MSM and intravenous drug users and female sex workers. And I'm wondering if studies have been done about the permeability between these groups and the general population, and whether they demonstrate any trends in how the epidemic can shift from these smaller groups into the general population of these countries.
Yeah, we have actually a lot of studies, but I haven't, in fact, this is one of the problems, I think, in the region. We have too many studies on general population because they are the easiest to actually study. It's much harder to study, let's say, a hidden population like men who have sex with men than the general population. I did not talk about them because there is nothing interesting actually over there. Simply, there is no HIV. Very, very little HIV infections among general populations. The epidemic is not moving from high-risk populations to general population. It's not. The only aspect that's moving is that usually, males transmit the infections to their actually wives. This is the only group, and wives very rarely pass the infection into the other people. So this is really in sum what we really know about the other groups.
Okay, thank you, Laith. We'll move on to the next session. Can we give a round of applause to Laith?